Bismillahirrahmanirrahim. Alhamdulillahi Rabbil Alameen. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. So we have actually started some of the important topics regarding the gastroenterology. Today I want to discuss the diseases of the esophagus, related to the esophagus, for the final year students basically. But those who are interested, who are appearing in the postgraduate examination, can also be benefited if they listen carefully. So actually these diseases which I want to discuss, this is a long discussion. I don't want to do the very long discussion. Esophagus, the prime function of the esophagus is the transportation of the food which is entered into the mouth, and it causes a bolus, rolled bolus, and it touches the pharynx where the peristaltic movements started, and it pushes the food bolus into the esophagus, and esophagus will transfer it to the stomach. Now this is the prime function of the esophagus. It means that swallowing is the prime function of the esophagus. Esophagus is lying in the posterior mediastinum, and it is called the sympathetic and the parasympathetic type of nerve fibers. Although it has got somatic sensations for the nosoreceptors which are present in the esophagus wall. It is lined by the epithelium which is stratified squamous. So these are the basics of the esophagus as far as you can understand well the disorders. Now the esophagus disorders are of many types. Mostly the disorders related to the motility. The motility disorders are common in the esophagus. And there are second type of the disorders which are called the inflammatory type of disorders. And there are miscellaneous esophageal disorders which are also important to understand because its prime function is the transportation. And the interruption in this process will cause basically the dysphagia, difficulty in the swallowing. The motor disorders are manifold, and I will discuss the inflammatory disorder actually, but some part I will tell you in very brief account will be given. Actually, I am Professor Sayyid Riyadh, and I am the visiting professor of medicine, talking to you. What are the motor disorders, motility disorders? All motility disorders can be very typical history given by the patient, reflecting it. Oesophagus is the condition in which the swallowing will cause the pain. Dysphagia is the condition of the difficulty in swallowing. It is not painful. These are best demonstrated by the barium examination rather than motility disorders are better examined by the barium swallow examination rather than the endoscopic examination. Although the upper GI endoscopy is very helpful. Now these motor disorders are from the stated muscles are concerned, like oropharyngeal paralysis, which occurs in the dysphagia, for example, in cases of many conditions related to the nerve supply is concerned. And it is the paralysis of these oropharyngeal will also involve the laryngeal muscle causing the hoarseness. And this type of the paralysis can occur other than the nerves are concerned in cases of the polymyositis, in cases of the myasthenia gravis, in cases of the motor neuron disorders. These oropharyngeal paralysis can occur. Another condition which is a spasmodic condition, which is called the cricopharyngeal bar. That is the failure of the cricopharyngeus muscle to relax on swallowing leads to a contracted type of the cricopharyngeus. So in this case, you can demonstrate it by the barium meal examination. Another condition causing the striated muscle involvement is the globus pharyngeus or globus hystericus. It is associated with the psychological disorders, and it is seen usually in cases of the women who have got multiple functional disorders associated with it. The globus hystericus is the subject which should be known to you, because if the person is persistently talking about the dysphagia and there is nothing which is present in any type of investigation, careful history will tell you about the globus pharyngeus or globus hystericus. I have seen many cases of globus hystericus in my practice during 40-45 years. Now, the disorder of the smooth muscles are concerned, they should be discussed with this scenario. That is, a 48-year-old known diabetic and a smoker, after binge eating at the wedding ceremony, was awakened in the midnight due to the heaviness and discomfort at the central chest, followed by vomiting. He was consulted in tertiary care hospital where examination was done. Temperature was 99 degrees, pulse was 110, BP was 170/100. Systemic examination was unremarkable. Nothing is present else in any other examination. Hemoglobin was found to be 17.4. TLC was 10,400. Platelet is 4,10,000. Random blood sugar was 210. ECG was normal on 2 occasions. There was past history of the chronic dry cough, and there was a history of a water brush, for which the patient often used the proton pump inhibitors and H2 receptor blockers and antacids for the last 2 years. Questions are: in this the differential diagnosis, give further investigations, justify the probable diagnosis and justify your diagnosis, and gives the lines of management. It is a true story which I have just told you. It is not a grey case. Extract soft data from it and extract hard data from it, from the scenario. And you will find after this, the hard data and the soft data, the differential diagnosis will be acute coronary syndrome, or it may be the Gerd, or associated with the hiatus hernia or hiatus hernia itself. It may be the diffuse esophageal spasm, DOS, or it may be the achalasia cardia, or it may be the acid peptic disease, may be associated with the Gerd or may not be associated with the Gerd. And this is the differential diagnosis. The first disease comes in the mind in acute coronary syndrome. It was ruled out by admitting the patient as SCS. After 4 hours, the troponins are normal, and all ECGs taken half-hourly were found to be normal. The history suggestive of there is something going wrong because the patient has already diabetes mellitus, which causes the neuropathies, autonomic neuropathies, and patient is obese, not following the proper management strategies for the hypertension and the diabetes. So it will enhance this problem. That is the smooth muscle problems of the esophagus, listed as achalasia cardia, diffuse esophageal spasm, are more important disorders to be discussed. As far as the achalasia is concerned, it means that, but achalasia cardia is concerned. Let me first talk about these two. The investigation of the cardiac enzyme and upper GI endoscopy, barium swallow is the main examination. Esophageal manometry can be done. Stool occult blood will tell you the ulcerative conditions or chronic conditions lying in the esophagus lower part, and the anti-H. pylori antibody indirectly will tell you you have to do the stool examination and for the H. pylori antigen. Now, what is the condition is achalasia cardia? See, this is the normal one. Here is the esophagus, which is entering into the abdomen. Here is the diaphragm muscles, which are crossover around it, and this is the flaps of the mucosa. And here is the other smooth muscles encircled it. It is called the lower esophageal sphincter. In this condition, there is a spasm of this sphincter, and it causes the contraction, spasm. And in this way, the food cannot be entered and blocked here, and the lower part of the esophagus will be dilated. This condition is known as the cardiospasm, or also called the achalasia of the esophagus. And try to understand the problem is actually it is the food which is here collecting the water you swallow will collect here and will go inside. But for example, the rice or the other small particles of the food will adhere here for a long time. So patient feels discomfort, definitely. And it occurs because of the loss of the intramural neurons, particularly the inhibitory neurons containing the VIP and nitric oxide synthase in the smooth muscle portion of the esophageal body and lower esophageal sphincter. So clinically, you find the dysphagia, chest pain, regurgitation, etc. in this condition. And diagnosis will be done by the radiology. It will see this is the part, you see it's the dilated part, will be seen very clearly with the smooth margin and barium swallow, dilated lower part of the esophagus, and the gastric aerogram is not visible usually. Here is the gastric aerogram. In the chest X-ray, it is gone. So the treatment in this condition is to dilate it. Actually. By medical therapy is concerned, the nitroglycerin can be given, calcium channel antagonists can be given, beta blockers are helpful to relax the muscle, and if all are failed, the perforation and bleeding, if these are the red flag signs. The surgery is called the Haller's extramucosal myotomy of the lower sphincter, or laparoscopic myotomy of the sphincter is also successful nowadays. And this is the achalasia cardia. Remember this condition because it is the differential diagnosis of the dysphagia. Another condition is diffuse esophageal spasm. In this case, the whole of the esophagus goes into the spasm, and it is associated with the various abnormalities of peristalsis in the diffuse esophageal spasm, which causing actually exact cause is not known. There are some irritating substances which are causing probably the spasm. So esophageal contractions are peristaltic, but large amplitude constitute a condition like you see here in this diagram, that it is just like this, spasms of the muscle will cause this thing. Look, the wave formations, it is called as what is known as the nutcracker type of appearance. If you go for the barium solo examination, very characteristic nut cracker, you know the nutcracker, it is instrument which you are using in your house to crush the nut. Just like this, there are spikes and wavy nature of the nutcracker is just like this. It is called nut cracker esophagus. So it will cause diffuse spasm, esophageal spasm, DOS. This is called as, it will cause the chest pain, it will cause dysphagia or both, and chest pain is not particularly marked in the patient with the esophageal contractions of the large amplitude and for the longer duration. Chest pain usually occurs into chest, but may be brought on by swallowing or by the emotional stresses. So it is easily diagnosed by it is a motility disorder of the smooth muscles, that is why it will be easily diagnosed by the barium swallow. The management is anticholinergics, if you use for the relaxation, limited value. The relaxation occurs with the smooth muscle, best you can give the sublingual nitroglycerin or isosorbide dinitrate will help this condition immediately. So those patients who have got the diffuse esophageal spasm, it goes in the ICU, where you put the nitroglycerin under the tongue and the patient was fine afterwards, then you label this condition usually as acute coronary syndrome. No, because acute coronary syndrome definitely have the diagnostic criteria. Not only the nitroglycerin that relieve the pain, yes, it can be, the nitroglycerin can relieve the pain of many things, like for example, eclasia cardia, diffuse esophageal spasm. In case of the Gerd, diffuse esophageal spasm can occur. It may be associated. Now, the other condition which I want to talk, that this is the barium swallow picture, which is given the nutcracker appearance of the esophagus entering now here into the lower part. It's constricted with the esophagus, but upper part is look. It seems that it is a carcinoma of esophagus. No, this is not the carcinoma of the esophagus. It's the contraction waves are seen very clearly. Even the endoscopy can be helpful, but this is more diagnostic, the barium swallow examination. About the inflammatory condition are concerned, which is the topic of today, is Gerd. It is the most probable diagnosis in our case presentation, Gerd. Gastroesophageal reflux disease associated with the hiatus hernia or not associated with the hiatus hernia. Now, Gerd here is actually here, where the esophageal sphincter does not close properly, and the stomach contents leak back into the esophagus, reflux esophagitis, that is. The lower esophageal sphincter is a ring of muscle at the bottom of the esophagus that acts like a valve between the stomach and the esophagus. So it holds the food. For the foreign food is coming here. The food enters. When it enters, it trying to enter. It actually opens, and when it lies in the stomach, it closes. In this condition, the valve is open after the filling of the stomach. You are taking and taking and taking, going down and down, and then because it is relaxed sphincter, the contents are going up. It may be acid, it may be anything from lower GI tract, upper GI tract. Anything can come into this and irritate the muscles of the esophagus, can cause the diffuse esophageal spasm. It can cause many complications. So main thing is there, the prevalence of Gerd is definitely 20% of adults have got the classical symptoms of the heartburn, water brush, regurgitation, and a very common condition. I would say that out of 100 patients, it is 15% at least in Karachi, Pakistan, which I am practicing as an internist. I usually see the cases often diagnosed on the history, very characteristic history. I do not need to do barium swallow examination. But a very characteristic history has been given by the patient. Actually, there are predisposing factors which causes this phenomena of the Gerd. But the very definite hard data is for causing it of the Gerd is the hiatus hernia. It may contribute to this herniation. This is the herniation of the mucosa of the lower part of the upper part of the stomach into the lower part of the esophagus, internal hernia. There is hiatus. Hiatus means where the esophagus enters into the abdominal cavity. So contributing factors are there: alcohol use, overweight, pregnancy, smoking. You are increasing the pressure. Intra-abdominal pressure is very high. In cases of diabetes mellitus, already neuropathy is going on, autonomic. It will cause these problems. Or other type of the peripheral neuropathies can cause the problems of the Gerd is concerned. This is actually the foods which can be associated with the reflux, even citrus fruits, chocolate drinks with caffeine, fatty and fried foods, garlic and onions, mint flavoring, spicy foods, tomato-based foods like spaghetti, sauce, chili and pizzas. All are fond of this. बताने का मकसद ये है कि सारे के सारे लोग इसको खाते हैं. अब मुझे ये बता दें कि इस पूरी जो पॉपुलेशन ऑफ कराची लेने चले, उसमें से चाहे गरीब आदमी भी हो तो वो भी जो है ना वो टेस्ट का भूखा है, वो टेस्ट के लिए खाना खाता है. Do not eat for the taste, but you should eat for the life, just to prolong your life, to stabilize your life. आप खाने के लिए नहीं पैदा किए गए, खाना आपके लिए पैदा किया गया. दिस इज द स्लोगन. हमारे उस्ताद कहते थे ना, जो आदमी जो है भूखा रहता है ना, या कम खाता है, या सुन्नत पे मन करता है, चले वो ये कंडीशन होती नहीं उसको कभी. वो आदमी जो कि ग़िज़ा जो है वो इस तरह खाता है कि जो आखिरी दफ़ा खा रहा है, उसके बाद उसको मौका नहीं मिलेगा. लास्ट टाइम ही इज टेकिंग नाउ, जिस लंच है या जो भी है डिनर, उसमें जो है ना वो क्या करता है कि बिंज ईटिंग कर लेता है. बिंज ईटिंग करता है, जैसे कि इस केस में भी आपने देखा उसने बिंज ईटिंग की थी और वो NICUD पहुंच गया, वहाँ ACS के तौर पे दाखिल हो गया. बाद में पता चला कि ACS है ही नहीं है. तो ये जो ओवर ईटिंग है, दिस इज द प्रॉब्लम. ये चीज़ें सारी पसंदीदा हैं किसी के लिए, इंसान के लिए भी, याद रखिएगा। फ्राइड आइटम ले लें, कोई भी जंक फूड ले लें आप, फ्राइड फूड ले लें आप, पिज़्ज़ास ले लें आप, ये ले लें आप, वो ले लें। अगर वो मुस्तकिल आदि है, कभी कभी खा लें तो कोई बात नहीं। ये सारी की सारी चीज़ें जितनी भी लिखी गई हैं, दे विल कॉज ओवरवेट, इट विल कॉज ओबेसिटी which is the mother of all illnesses. You are prone to develop this patient to the different complications afterwards. Metabolic syndrome, for example. Symptoms तो जाहिर है कि इसके अंदर में definitely there are persistent heartburn, belching, water brush, sore taste. The acid is going here, wherever it is, it can be reached because it's ciliated type of epithelium. It is ciliated epithelium means that it can go against the paracelsus. The reverse paracelsus will occur in this condition, and it will help this food to come in the mouth, or in the throat, or in the nose, or in the larynx, or in the trachea, even in the, it is but demonstrated in the middle layer. How it can reach the middle layer? Because of the eustachian tube. Yes, of course. So the thing is this, it will go down into the larynx, it will cause dry cough, bad breath. In the mouth, it will cause inflammation of the gums and erosion of the teeth, malformation of the teeth, enamel, the discoloration of the teeth. And Gerd is one of the commonest causes of the chronic dry cough. One of the most commonest causes, I would say. Is GERD. Second commonest cause of dry cough in this country is chronic maxillary sinusitis. Third is tuberculosis. Fourth is sarcoidosis. Now this is how I approach it. Based upon my previous experiences, I have more than 1,000, 2,000, 3,000 patients. Actually, you will see the duration and severity of symptoms. Anemia occur in these cases because of the hurry, abdominal hurry. The iron is absorbed from the stomach when it is converted from the ferrous to ferrous with hydrochloric acid. It needs to bound what is called vitamin C. You can cause the macrocytic anemia because intrinsic factor is not able, gastric binder is not available properly, it will cause anemia. It may be macrocytic, hypochromic, it may be just like megaloblastic anemia. Weight loss occurs because the patient is not able to eat properly. The thing is this. The dysphagia, difficulty in swallowing. Now, if these are on your clinical examination, and you will see it, yes. You can give a therapeutic trial can be given by the antacids or by prokinetic agents. You can do the ambulatory ECG monitoring. You can do the upper GI endoscopy. But the gold standard diagnostic criteria is barium swallow examination. On the endoscopy, you see this is the inflammation. Normal upper GI endoscopy, this is the part, the reddish part. Now see what happened here. According to Lee, the Los Angeles classification system was developed, endoscopic. Grade A is one or more mucosal bracts, no longer than 5 mm, none of which extend between the tops of the mucosal folds, just like this. Grade A. Grade B is one or more mucosal bracts more than 5 mm, none of which extend between the tops of the two mucosal folds. It does not intermingle. Grade C, mucosal bracts that extend between the tops of now the two or more mucosal, more than 5 mm, maybe 7 mm. The two tops of the two mucosal bracts will meet, but which involve the less than 75% of the esophageal circumference. This is the circumference. It is grade C, and grade D is the mucosal bracts which involve at least 75% of the esophageal circumference. More than that, 75% circumference here mucosal bracts, you see, it is grade D. Other than that, there are stages again. It will cause the Barrett esophagus, where the squamous stratified epithelium is lined by the gastric mucosal epithelium, that is columnar type of the epithelium, and that is called the Barrett esophagus. So it will cause this. The Barrett esophagus is grade E then afterwards. So actually the thing is that endoscopic examination is difficult. Every patient will not agree. And monitoring is of the acid on the tongue can be demonstrated by the pH testing, or you can do the manometry. These are all examinations are not accepted by the patient. And under condition, non-acidic reflux, because it may be bile. It may be bile. So it is not usually, in 90% of cases, are the acids. In 10% it may be other secretions, succus entericus, bile can come into the esophagus. The pH monitoring is limited. It is a good test, but difficult to perform. A catheter-free pH monitoring system, Bravo catheter-free pH testing it is. And Bravo, it can be placed during endoscopy into the lower part of the esophagus, and you will do the 24-hour to 48-hour. It will give signal outside. Just like anything, you go 24-hour monitoring of the blood pressure or 24-hour monitoring of the heart rate, etc. This is ambulatory type of the monitoring. Bravo, it is called Bravo, but it is actually not cost effective. So, Gerd can only be diagnosed confidently with the barium swallow examination. You remember this. Treatment is you have to go for the lifestyle changes, lifestyle modifications. You will give some certain medications. If the medication fails, you go for the surgery. Whether it's open surgery or through the endoscope. Lifestyle changes, yes, that will work. Lose weight if needed. Do not drink alcohol or any drink, beverages, cold drinks. Smoking will enhance. Stop it. Rather give the large meals you will eat small meals. Do not try to take water just after meals. You can take water before meals, is better. Wear loose fitting clothes, belts, etc. Avoid lying down for 3 hours after a meal. After 3 hours you can lie down, otherwise you should sit up in 90 degree. Pillows should be used, 2 pillows, 3 pillows. 30-degree angle of the bedside is needed at the home. And do not pressurize the abdomen in any way. नीचे बैठना मना है, नीचे बैठकर डिफिकेशन करना मना है, नीचे बैठकर काम करना मना है इसमें. अगर आप लाइफस्टाइल नहीं करेंगे अडॉप्ट मॉडिफिकेशन को, तो फिर ये रिफ्लक्स, एसोफेगाइटिस या जर्ड जो ये बार बार होगा, रिलैप्स रिमेट, and it will cause what is grade D classification I have told you, mucosal bracts and cause the what is called Barrett esophagus with the precancerous condition. We use the therapy, the pharmacological intervention afterwards, the Malanta or what is called as there are many antacids present here. Magnesium chloride, magnesium sulfate, aluminum hydroxide. Foaming agents like Avascon is helpful. Type blockers should be given cimetidine, famotidine, azatidine or ranitidine, although ranitidine is banned nowadays. It was the drug of choice at one time. It is not banned, famotidine. It is easily available. 20 milligram tablets, 40 milligram tablets. Or you can use the PPI, which are the gold standard pharmacological therapy. Omeprazole, lansoprazole, deslansoprazole, pantoprazole, rabiprazole, and the esomeprazole, which is the prodrug of the omeprazole. These are all effective agents you have, very powerful agents. And they should be given in the larger doses, which we are using, and the acid peptic disease should be double that dose. For example, the omeprazole 20 milligram is enough. But in this case, not 20 milligram will be given, it will be given 40 milligram. Should be given at least twice a day. I use actually the 20 milligram omeprazole 6 hourly in these conditions for a month, and then I taper it, the dose of the omeprazole or lansoprazole or deslansoprazole, etc. or pantoprazole. Very effective agent. The prokinetics agent should be associated because the anti-peristaltic movement is a problem. Then domperidone is the drug of choice. The metoclopramide we are using here, etopride nowadays is very helpful. These agents are the prokinetic agents. Methanicol is not available usually. It is the cholinergic drug, but it is not available. Motilium is available, domperidone. The maxilon is available, metoclopramide. And etopride is available as Ganaton or the ITP. It will be given the higher doses with the proton pump inhibitors, or you can give with the H2 receptor blockers. You can give the double blocker also in some conditions. H2 receptor blocker plus proton pump inhibitors plus prokinetic agents. As a last resort, what is called the nasal fundoplication. It is done is like this. Open it at the epigastrium, the lower esophagus sphincter will be tied with the sutures, and these sutures are specific type of sutures which we apply here. उसकी टेंसिबिलिटी ज़्यादा होती है, वो आहिस्ता आहिस्ता जो है ना वो खुद ही उसको मैनेज कर देते हैं, एंड दी डायलेटेशन ऑफ द जो परमानेंट हो गया है एसोफेजियल स्फिंक्टर का डायलेशन, उसको कम करने की कोशिश की गई है आफ्टर सर्जरी. You can do the endoscopic fundoplication also from inside. ठीक है ना, it may be done from inside. This is the nasal fundoplication. Nasal fundoplication can be done via endoscopy. From inside you will apply sutures around it and tie it. It is easy to do it. But as a last resort, long-term complications of Gerds are there, you have to treat to manage it. Inflammation of the persistent inflammation of the esophagus, bleeding of the ulcers, form stricture, barren esophagus, and is a precancerous condition causing adenocarcinoma, supraesophageal manifestation because acid comes and irritates the larynx and the trachea, etc. They will cause asthma, and chronic cough is the commonest cause, I say. It can cause, it lower down to the bronchi and bronchioles, cause the pulmonary fibrosis, and it causes the ENT manifestations in the nasal cavity, in the middle ear cavity, it will be a problem. So these are the endoscopic pictures of the Gerd is concerned, which are showing to you. And extraesophageal manifestation, I already told you. Non-cardiac chest pain, pulmonary condition, asthma, chronic cough, recurrent bronchitis, sleep apnea, pulmonary fibrosis. Laryngeal diseases like laryngitis, subglottic stenosis can occur, laryngeal cancer, or either ENT disorder like sinusitis, otitis media, pharyngitis, dental erosions. Look how the acid reaches and it causes the problem. So non-cardiac chest pain is associated with the Gerd. So this is I have presented the case in front of you. The total non or atypical chest pain, it is seen between 0% to 47% associated conditions with the non-cardiac or atypical chest pain. So cough occurs, yes, of course, I have already said about it. But in some condition, it is non-acid gastroesophageal, which is the bile and succus entericus will reach into the esophagus and irritate it. And it can reach into the throat. It is very, very bitter. And it is greenish in tinge. It is a greenish type of the patient, if spit out, it will be green in color. So it is possibly that the non-acid gastroesophageal reflux occur, other than the it may be pepsin or acids. So it is the gastroesophageal reflux which can cause the atypical chest pain and the other associated problems like chronic cough, laryngitis, the dental caries and maxillary sinusitis. So actually the thing is that the importance of the non-acidic reflux, the pathogenesis of both esophageal and extraesophageal symptoms remain to be established. You have to go to pH monitoring if it is basic in nature. It is not the acid, it is something else, succus entericus, or it is from the bile. Actually, the Gerd and the chronic cough is associated. I already said that it is one of the commonest causes. I don't want to go into detail about it, how it occurs, and how it causes the chronic cough. It is a pathogenesis. So all these are the studies, actually, which has been done. But you have to understand that this is a condition which can cause the extra-intestinal manifestations other than the intestinal manifestations. Another condition is called the laryngopharyngeal reflux, where the normal esophagus is there, but that 40% may have symptoms of heartburn in this condition. It is actually more lateralized towards the larynx, the dysphonia, global sensation, throat clearing, halitosis, stasis of the sputum inside, sore throat, cough. Hoarseness is the major complaint in most of the cases, hoarseness. Now here is the pharyngeal reflux. So actually the thing is that it may be associated with this condition that I will tell you that Gerd is the associated condition. Reflux laryngitis occurs the same way. And reflex laryngitis will treat it, you have to treat the Gerd first. You have to manage the Gerd. And the non-pharmacological lifestyle modification with the drugs, which I have told you in higher doses will be used. I am using the triple therapy, that is HT receptor blockers plus PPI plus prokinetic agents, and it is for prolonged duration. unless the condition subsided or the lifestyle modification he achieved will probably solve the problem forever. So, even otitis media, and it is associated with the sleep apnea also, the obstructive sleep apnea. There is a strong association between the sleep apnea and the Gerd, obstructive sleep apnea and the Gerd. And obstructive sleep apnea is the risk factor for the hypertension. It is a risk factor for the coronary artery disease also. उसको ब्लूज ना छोड़ें. जैसे किसी को अगर है, the cause may be Gerd. The Gerd, if you treat it, you will also relieving the obstructive sleep apnea in this condition. Mostly these patients have overweight and they are using very high caloric diet. So these causing the obstructive type of sleep apnea. The conclusion is this, that the patient with the obstructive apnea may be predisposed to Gerd or vice versa. The obesity, sedentary lifestyle, alcohol use, smoking. So this is, there are a lot of studies done on it. Asthma can occur, yes, wheezing because of the irritation of the larynx and the bronchi. You have to give the symptomatic management of the beta, as a LABA or what you use the SABA, but the basic condition should be treated. Underlying is the Gerd. Manage the Gerd, and symptomatically you will give the bronchodilators for a prolonged period of time with lifestyle modifications. The conclusion is that the GERD is a very, very common condition. It will cause the typical type of the symptoms and the atypical symptoms, extraintestinal that is, and is one of the very important cause of the non-cardiac pain, that is atypical chest pain. So, we will go for this lecture now to end it, that I hope that you have understood most of the part of the esophagus. The last thing, but not the least thing, it is associated with the hiatus hernia. It is associated with the hiatus hernia, which is a part of the actual surgery. Now, the hiatus hernias are maybe formation of sliding type of the hiatus hernia, where the another condition is the rolling type of the hiatus hernia, that is called paraesophageal. Whatever it is associated mostly with the Gerd. So if you manage the Gerd, the hiatus hernia will be treated parallel to it. So this is the part which I have taken. I hope that you have understood well, and if you remember these sentences which are quoted by me, I don't think so there will be any problem in the near examinations. Thank you for the listening. Jazakumullah khairan kaseera. Wa ma alayna illa al balagh. Assalamu alaikum wa rahmatullahi wa barakatuh.